Thank you for introduction. Hello, everyone. So, as I told before, that I work as a research coordinator in the Medical Imaging Center of Southwest Finland of Turku University Hospital. And this is my first time in the UK and in Birmingham as well. So there's so much to see and wonder at. But in this presentation, which is based on my PhD work, I'm going to tell about our experience of setting up local diagnostic reference levels in endoscopic retrograde cholangiopancreatography, which is abbreviated as ERCP. And the presentation complies with the following structure: introduction, materials and methods, results, discussion and conclusion as well. International Commission on Radiological Protection expressed concern about the fact that the use of fluoroscopy outside imaging departments has increased significantly and expanded to the larger clinical areas. And there has been a general neglect and a lack of training, knowledge and awareness regarding radiation protection among of those working with fluoroscopy outside imaging departments. Gastroenterology is one of the specialties which use fluoroscopy to aid endoscopic procedures such as ERCP. ERCP is a highly technical and demanding invasive procedure used as a gold standard in the treatment of hepatobiliary disorders. Nowadays, ERCP may be performed outside imaging departments like in operating theater or endoscopy units. During ERCP, both patients and medical staff are exposed to radiation, and this makes the ERCP undoubtedly an interventional radiological procedure. However, ERCP is not generally performed by a radiologist, but by a gastroenterologist or by even a general surgeon. In recent years, there has been a continuing and increasing interest in patient radiation dose, particularly from the interventional radiology and cardiology, because of remarkable growth in frequency and complexity of the procedures. Several studies have been performed in response to growing interest in patient radiation dose from ERCP as well. It's notable that these interventional procedures may cause a high radiation dose to the patient and lead to the radiation-induced skin injuries. Therefore, fluoroscopically guided interventional procedures are now an area of special concern in relation to radiation protection. It has been recognized that application and use of diagnostic reference levels represents an efficient and substantial standard for radiation protection of patients and optimization of fluoroscopic procedures. Diagnostic reference levels are defined as dose levels in medical or interventional radiologic practice for typical examination for groups of standard-sized patients or standard phantoms for broadly defined types of equipment. The DRLs is not applied to individual patients, but it is used for a given medical imaging task or protocol. Basically, the objective of DRLs is to help avoid excessive radiation dose to the patient that does not commensurate with the clinical purpose. DRLs are typically set at the third quartile of the dose distribution, as shown in this picture, and available information regarding DRLs for ERCP is unfortunately quite limited. Only in a few countries radiation protection authorities have suggested or already established national DRLs for ERCP, and these all values varied greatly according to the literature. Currently, there are no existing national DRLs for ERCP in our country, proposed by Radiation and Nuclear Safety Authority in Finland. While the national levels are unavailable, it is recommended to establish local DRL for specific procedure, which is based on local practice. And the aim of this study was to describe the current level of patient radiation doses during ERCP in our hospital and to establish local DRLs for optimization and for quality assurance management. And this study was carried out at the Medical Imaging Center of Southwest Finland of Turku University Hospital. Patient exposure data were collected over a 4-month period in 2010 by local personnel of radiological department. A total of 105 patient radiation doses in ERCP were recorded without setting any restriction on patient weight, sex, or condition. For each procedure, dose area product, fluoroscopy time, and the number of radiographic images were collected as well. Patient body characteristics such as age, sex, height, weight, and body mass index were registered. And the fluoroscopic system used in ERCP was a Philips multi-diagnosed ELEVA equipped with a multi-purpose C-arm and with image intensifier of 38 centimeter field size in diameter. During ERCP, pulse fluoroscopy with lowest possible pulse rate was used, and the X-ray beam was modified by collimate the field size to the region of interest in all procedure. In ERCP, an X-ray tube located under the patient table, so there was undercode system, and equipment was controlled by a radiographer. In order to establish local DRLs for ERCP, the third quartile method was adopted in this work. A data of 5 patients was excluded from the analysis because of extreme values in patient weight. The local DRLs for ERCP were established in terms of dose area product and fluoroscopy time. The proposed DRL values are then rounded up to the integer number. And in this year, in 2015, the local DRLs for ERCP were reviewed by collecting the similar data of 20 patients in weight class of 65 to 85 kilogram. The average dose area product and fluoroscopy time were then compared with the local DRLs established in 2010. All data, the original one and the reviewed as well, was analyzed with the statistical software. And then results. A total of 100 ERCP were investigated in the study, and most of the procedures were therapeutic in nature. According to results, in current data, approximately half of the patients were male and half were female. The mean age for all patients was 65 years, ranging from 24 to 89 years. And the mean weight of all patients was 77 kilogram. In this study, males were about 12 kilogram heavier and 15 centimeter taller than females. Patient body characteristics are summarized in table 1. A large variation in radiation dose, fluoroscopy time, and in the number of radiographic images was observed in the study, as seen in Table 2. During ERCP, patients receive on average 2 gray in square centimeter of radiation dose, and the highest dose or product value recorded in the study was over 9 gray in square centimeter. The mean fluoroscopy time found to be 1.7, ranging from 0.4 to 7.8 minutes. And the number of radiographic images taken during ERCP varied from 0 to 9 images, and the mean number of images was 3 in this study. The distribution of dose are a product and fluoroscopy time were asymmetric, with a large positive tail as shown in Figure 1 and Figure 2. And between the dose or a product and fluoroscopy time was found a strong linear correlation in this study. DRLs were chosen as the rounded values of the 75th percentile of dose or a product and fluoroscopy time distribution. Consequently, the proposed local DRLs for ERCP were 3 gray in square centimeter and 3 minutes in this study. And local DRLs were reviewed after 5 years. They had been established in our hospital. And in the sample of 20 patients, the average dose or a product and fluoroscopy time were 2.54 gray in square centimeter and 2.1 minutes respectively. And the average weight for all patients in reviewed data were 74 kilogram. Dosimetric measurements and patient demographics in original and in reviewed data is presented in Table 3. In reviewed data, the average dose or a product and fluoroscopy time were both below the local DRLs. The dose or a product was 15% lower than local DRLs, and the fluoroscopy time was even 30% lower than local DRLs established in 2010. And the discussion. The study presents the results of patient radiation doses in ERCP collected from a single center and describe the method and describe the method of establishing and reviewing local diagnostic reference levels as a practical tool for dose optimization and for quality assurance management. Setting up local DRLs for dose-intensive fluoroscopically guided procedure, such as ERCP, was a challenge due to the large variation of patient radiation doses and fluoroscopy times. Another challenge in establishment of local DRLs is associated with the difficulties in achieving sufficient sample size because of the lack of standard procedures and standard-sized patients in fluoroscopically guided procedures. The complexity of the decided procedures clearly depends on the patient underlying anatomy and physiology, as well as on a clinical problem of the patients. And today it's well known that obesity is a large clinical problem in developed countries, so there are no standard-sized patients. And today more and more of male patients are like Santa with a big balloon in the stomach. But for a single practice, it is recommended to use reference levels that have not been corrected for the body habitus, as they would be more representative of typical local practice. And established local DRL values for ERCP in the study become a tool for the daily follow-up of patient radiation doses in our hospital. In reviewing data collected in this year, the average dose area product and fluoroscopy time were below the local DRLs established in 2010. In spite of that, there is no current need to decrease established local DRLs in ERCP because there were not so significant decrease in radiation doses overall. I think this battery is quite low. Let's see if it's enough. But if reference levels are not exceeded, this does not automatically guarantee that the procedure has been performed optimally and optimized for radiation safety. It is still necessary to ensure that image quality is enough for reliable clinical diagnosis, and in some circumstances, doses above the reference levels can be justified. For those reasons, it's very important to record routinely and regularly the patient radiation doses and compare them with the reference levels, the local one or the national if they are available. DRLs should be reviewed especially when there is significant change in protocol or in the fluoroscope equipment and where they are consistently exceeded. And to sum up this presentation, so the increase in frequency and complexity of ERCP procedures indicates possibility of increase in radiation exposure to patients and as well as to medical imaging staff. It's obvious that all actions to reduce patient dose will also reduce staff dose. The DRLs play an essential role in the optimization process of fluoroscopic procedures and guides to a good clinical practice. Moreover, DRLs help to identify the fluoroscopy equipment, protocols, and practices that may be delivering unusually high radiation doses to the patient. If the national DRLs does not exist, the setting up local DRLs based on own local practice is a viable option. And this picture is from my home city. We don't have so much canals as in Birmingham, but in Turku we have the big Aura River, and it's a very beautiful place in the evening. Thank you for listening.
Thank you very much. Questions or comments? Please. Have you done any correlation on other ex-CR units or non-CR units to those area products that you're getting on that?
Yes, I have one publication where I collected information in 10 different hospitals around Finland, and there was some difference between the hospitals.
So was that the equipment or was that the radiography?
There was different equipment used in the ERCP procedure. There was different practices in ERCP. Some of the hospital radiographer controlled the equipment, but in some hospitals the equipment was controlled by nurse or surgeon. Yes?
Do you have any national dose reference levels so you can compare?
No, we don't have. It's the problem. Only in fluoroscopically guided procedure, only cardiology procedures have reference levels, which my colleague speak in the next presentation.
Is there any discussion about what you've done is to reduce quite a complex curve to a single number, which is
Yeah, I think that the next step we need to collect more information about the complexity of the procedures, how many procedures is done during the ERCP, what kind of procedures, what kind of fluoroscopy times they require. So that's way we can get more information behind the dose variation.
I was thinking more that if I go to see my doctor and say I'm worried about the level of radiation I'm receiving, from your data I could have received maybe twice the dose that you've recorded as the DRL. Yes.
Exactly, the doses in ERCP in our hospital is quite low comparing to another hospitals, but it's depends.
But even within your hospital, the range of level doses
Yeah.
is quite substantial.
Yeah, because they're so different. The complexity is quite products, because some patients have the clinical problems which need more fluoroscopy time to solve. Yeah.
I was thinking more of it from a statistical parameterization point of view rather than the underlying medical problems. That if you have a curve like that, if you record two moments of the curve, then you will know the whole curve.
Yes, it's based. This presentation is based on my PhD work, so I'm working with it all the time.
Please.
I will follow you well, but your study have been done in university center.
Yeah.
Center.
Yeah.
You do have MRI in each hospital?
Yes, we have.
Because nowadays we come the use of endoscopy,
Yeah, we have.
common.
Yeah.
Can use
Yeah.
MRI.
Yeah, we have MRI, and I say maybe almost all diagnostic procedures done in MRI or in ultrasound. But if there are some situation that patient need interventional, so then we do this ERCP, because if we perform MRI, we just can see that there's some problem, but if example there are some stone, we can remove them by MRI. So that's why we do ERCP.